Hi, everyone. It's Dr. Sadaf, and I have some exciting news. I want you to know that I am seeing patients now in North Carolina. So I can now do telehealth for New York, Michigan, and North Carolina. So if you know of anyone or if you yourself are experiencing perimenopausal symptoms, menopause, or any type of sexual dysfunction, you can schedule an appointment with me by going online at www.femvhealth.com and you can schedule your appointment. And I am so excited to invite you on September 10th, 2026 for my 2-year work anniversary that I'll be hosting at my office. It's 26 South Greeley Avenue in Chappaqua, New York, Suite 5. And come join us. I will be doing a little talk on Menopause 101, but there will be some raffles and prizes and lots of 80s music. So if you are excited to venture into this stage of life, then I'd love for you to join me at my 2-year work anniversary on September 10th. Make sure you go to my website at www.femvhealth.com to register, and I'll see you there. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about insomnia and sleep and all the great things that can happen in midlife. Before we get into it, a few things that I want to make very clear is, of course, this is not any type of medical advice. So if you have any questions about your health, make sure you go speak with your healthcare provider. And if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I'm super excited to have on with me Dr. Nishi Bhopal that comes to us from San Francisco. Dr. Bhopal, welcome to the podcast.
Thank you so much for having me.
Yeah, for all those individuals that may not know who you are, if you could just please introduce yourself and let us know about yourself.
Great. Well, thanks again for having me. I'm really excited to talk about my favorite subject, which is sleep. So I'm Dr. Nishi Bhopal. I'm board certified in sleep medicine, psychiatry, and integrative medicine. I am the founder of a practice called Pacific Integrative Psychiatry, which is a telehealth practice in California. And we see adults with anxiety, depression, and insomnia. I'm also the founder of IntraBalance, which is an online educational platform for health practitioners. I'm known as the sleep psychiatrist online, so if you want to find me, you can find me there. But I teach physicians, healthcare practitioners, nurse practitioners, PAs, therapists, and so on, all about sleep medicine, because most doctors only get about 2 hours of sleep education in their training, yet every patient has to sleep. So I have an online integrative sleep fellowship that I offer, and I also have an online insomnia coaching program for people with insomnia, and that is called Effortless Sleep.
That sounds so exciting. Awesome. Well, thank you. And welcome to the podcast. So I'm so curious as to your journey, with psychiatry and sleep medicine. What made you interested in the connection between both of those?
Yeah, I mean, I didn't know that sleep medicine was a specialty when I went into my residency. So I actually started out doing internal medicine. So I did a year of internal medicine. I was always interested in psychiatry, and I pretty quickly realized, I think I'm in the wrong specialty. I was talking to my patients about their mental health, about their lives, about what they found meaningful, and what gave them a sense of purpose, and all of these things that we explore in psychiatry. And my internal medicine attending was like, we don't have time to talk about all of those things in a visit. So I was like, okay, you know what? I think I'm in the wrong specialty. So I ended up transferring into psychiatry. And for anyone who's in mental health, that if patients are not sleeping well, it's really hard to help them with their mental health. And about 90% of patients with, in the psychiatric clinic are going to have some kind of sleep disturbance, whether it's insomnia, hypersomnia, sleep apnea, or something else, restless leg syndrome as well. There's all these different sleep disorders that show up in the psychiatric clinic. And I felt like I just wasn't getting a good handle on how to help those patients. And at the same time, I was dealing with my own sleep issues. I've always been someone who's been on the sleepier side, like always sleepier than my peers, feeling like it was hard to, get up for classes on time. So residency was pretty brutal. Sleep deprivation is kind of the name of the game when you're in residency. So I was struggling with my own sleep issues. I'm seeing patients with sleep disturbances. And actually, one of my senior residents from internal medicine was going into a sleep medicine fellowship. And I was like, what is that? I've never heard of this. Sleep medicine. That sounds interesting. This is back in, 2010. So back then, sleep was just not as common a topic of discussion as it is now. And so she went into that fellowship, and that piqued my interest. And so I started doing rotations at my hospital where I was doing my residency. They have a big sleep clinic there. And I just fell in love with it. I found it so fascinating. Sleep is truly multidisciplinary. And so then that kicked off this journey of doing a sleep medicine fellowship. And then over the last decade or so of my career, really focusing in on sleep disorders, specifically holistic approaches to insomnia.
So, why do you think that so many women struggle with insomnia even when they think they're doing all things right? And actually, before we even get into that topic, I'm so curious to know. We know that, perimenopause and menopause, which is something that I talk about a lot on this podcast, really wreaks havoc on sleep. And so I'm wondering if you can talk a little bit about the midlife changes that happen in regard to sleep. We know that, hot flashes and night sweats definitely can cause disruption. Decline in estrogen can cause a disruption. But maybe you can speak a little bit about that.
Yeah, and this is a really personal topic for me too, being in that phase of life and dealing with those sleep changes in myself, and then supporting my patients through this time as well. So sleep issues are one of the most common complaints that women have during perimenopause. And sometimes it's one of the first thing that shows up before they even have vasomotor symptoms or some of the other telltale signs. There are many different reasons that women have sleep issues in perimenopause. Hormones are one part of it. It's not the only piece of the puzzle. There's other aspects that contribute, which I'll share in a moment as well. But when it comes to those hormonal shifts, we have this sort of zone of chaos that we're in during perimenopause where, estrogen is fluctuating, progesterone is declining, but fluctuating. And those two hormones play important roles in mood and sleep regulation. So progesterone is important for calming. So I think of that as like a calming hormone. It helps with GABA production, GABA being an inhibitory neurotransmitter that's important for sleep regulation. So when we have that decline in progesterone, then we're not getting that calming effect from from that hormone. And that can cause some sleep disruption, difficulty falling asleep, but difficulty staying asleep is the most common complaint that women have in perimenopause. With estrogen's a little bit more complex because it's more of a sleep wake regulator. It works in, more than I do about estrogen. There's receptors all over the body, there's receptors in the brain. And when it comes to sleep, it's involved in sleep wake regulation. So it's not just a sleep, promoting type of hormone, but it also is important for thermoregulation. So when we have that decline in estrogen, our body's just not able to regulate its core body temperature as much. And a reduction in core body temperature is important for sleep onset and sleep maintenance. So when we lose that regulatory function with that decline in estrogen, then we get those vasomotor symptoms, the hot flashes. And, I know personally, just feeling so hot, it's uncomfortable. And that is antithetical to sleep because we need coolness in order to sleep. So that's where the hormones can kind of start to wreak some havoc on sleep quality. But it's not the whole story because sleep is multifactorial, like I was saying. So there's also psychological aspects. There's behavioral aspects. There's work demands. This is a time of life where women are juggling many things. They're maybe taking care of kids and aging parents. They may be at the peak of their career or, have more demands at work. They're juggling so many different things in their lives. So there's the psychosocial demands plus the hormonal changes. Many women just, sleep is the first thing to go when they're really busy. So if they have to do all these different things, they're not necessarily prioritizing sleep. I see this with women in my practice where, I have this one patient she's staying up really late just to catch up on things at work because after she took care of what the kids needed and cooked dinner and, did her cleanup and stuff, that was the only time she had for herself. So sleep is the first thing to be sacrificed. So there's all these different aspects that come into play. And then sleep disorders on top of that. There's an increase in the risk of sleep apnea during this time of life. And it shows up really differently in women. I'll pause here because I know, we can go into those aspects, but there's all these different pieces of the puzzle.
Yeah, no, I mean, this is also very interesting, and I think that, I mean, yeah, you're absolutely right. I think that a lot of women that come in, because my whole practice focuses on midlife women. And so I would say that, yeah, sleep is definitely one, if not the most important thing that people come in complaining about, that they are not sleeping well. And of course, if they're not sleeping well, they're exhausted. And if they're exhausted, they really can't function throughout the day. Plus, they have like brain fog, plus their energy is just gone down because they're just not sleeping. And even when it seems like, they may be getting enough sleep, they still are not sleeping well. And so, that causes exhaustion. Let's talk a little bit about the sleep apnea that you just mentioned. I'd love to hear more about that because I know that that shows up in midlife, and people don't necessarily need to be overweight to have sleep apnea.
I'm really glad you brought that up because this is one of the biggest misnomers when it comes to sleep apnea. Even as a sleep doctor, when I'm working with a patient and I highly suspect she has sleep apnea, usually what they'll say is, "No, there's no way I could have that. I'm not overweight." So let's dispel that myth right now. Sleep apnea is not necessarily related to weight. Yes, weight is a risk factor for sleep apnea, but not everybody who has sleep apnea is overweight, and not everyone who's overweight has sleep apnea. Now, one of the big limitations with sleep apnea, with the understanding of it, is that the majority of the research in sleep medicine, and this applies to medicine in general, is the majority of the research has been done on men. So the classic archetype that we have in our mind of the patient with sleep apnea, the overweight male with the 17-inch neck with the loud snoring and gasping arousals, that is what we see in men often. It does not look like that in women. In women, it can look like irritability. It can look like fatigue. It can look like fibromyalgia, aches and pains. It can look like depression. And I see so many women, it looks like insomnia because they have trouble staying asleep. So I've seen so many women either misdiagnosed with depression or misdiagnosed with treatment-resistant insomnia when they actually had sleep apnea. So last year, I actually had 4 women who were referred to me for treatment-resistant insomnia by other psychiatrists. And they know I specialize in sleep, so they referred these patients to me, all midlife women. And the first thing I did on all of them was do a sleep study. And they all, they had all been through the usual like trazodone and, zolpidem and Klonopin, like all the usual things for insomnia. Nothing was working. Did sleep studies on all of them, and they all had moderate to severe obstructive sleep apnea without the classic symptoms. They had all had a chief complaint of, I can't stay asleep and I'm tired no matter how much sleep I get. And so I really encourage people to, physicians, and if you're a patient listening to this, think about sleep apnea as a contributing factor to your sleep difficulties, even if you don't snore, even if you're not overweight. If you're feeling tired all the time or you're having trouble staying asleep, the reason it is more common during midlife and then postmenopause is because with the change in hormones, our airway tone is less, it's more collapsible. So progesterone helps keep our airway open. And with that decline, our airway becomes more collapsible over time. And there's other aspects as well. It's not as simple as that. But what we see is once women get into menopause, rates of sleep apnea double or even triple, and they become equivalent to that, the rates that you see in men. It's just that the symptoms look very different.
So that's so interesting that you mentioned that about progesterone, and so many women, so I send women for sleep studies as well, because I've had actually a conversation with a previous sleep doctor who also mentioned the same thing about how we're not diagnosing sleep apnea enough in midlife women, and they don't necessarily need to be overweight. Actually, in fact, I'm going for a sleep study myself because it's the same thing. Like, I just don't feel rested even when I'm, sleeping. And my family is tells me that I snore. So I'm like, all right, well, it's time for me to figure this thing out. So interesting. And so, why women can struggle with insomnia even when they think they're doing all the right things. So, we talk a little bit about sleep hygiene, and maybe you can talk a little bit about that. I am like, I'm always telling my husband, I'm like, you are on your phone. I'm like, first of all, you complain, you can't sleep, you don't sleep well. I go, but you're on your phone literally till the second you close your eyes. I'm like, so how are you ever going to get, like feel tired enough to sleep and stuff like that? So maybe you can speak a little bit about, sleep hygiene, and then maybe talk about what women are getting wrong, even though they think they're doing all the right things.
Great. Okay. Yeah, I think sleep hygiene is a good place to start. So, sleep hygiene is a lot like dental hygiene, right? So dental hygiene is a way to keep your teeth healthy, but then if you have a cavity, you need more than dental hygiene. You need a treatment plan, right? You need to see a specialist, see a dentist for that. So sleep hygiene is like that. It's a way to keep your sleep healthy. These are sleep promoting behaviors, but if you're dealing with a sleep problem like insomnia, sleep apnea, or something else, you need to work with a specialist to address that. Sleep hygiene is not enough of a treatment. It's a foundation. So, what is sleep hygiene? These are sleep promoting behaviors that everybody can engage in. So, you mentioned the phone. There's, putting your phone away at least an hour before you go to bed. I know that's not always, easy for people to do. These phones have really taken over our lives. They've hijacked our brains. So, if an hour feels like too much, make it 30 minutes before you go to bed, and put that away. Why do you want to do that? Well, there's light exposure that can, stimulate your brain. But beyond that, there's a lot of information that your brain is taking in. Even if you're looking at cute puppies, right? You're scrolling through, it's still a lot of information for your brain to process. And our brains have not evolved to keep up with that much stimulation. So it just keeps your nervous system in this active state. Whereas when we want to go to sleep, we have to downshift, right? We have to go into our parasympathetic rest and digest state. So putting the phone away is a great practice. The other thing I recommend in the evening is to dim the lights after about 7 or 8 p.m. And that sends a signal to your brain that it is nighttime. It helps your brain produce melatonin because our brain produces melatonin in response to darkness. My family makes fun of me because they're like, you're always sitting in the dark at night. I'm like, yeah, I'm a sleep doctor. I have good sleep hygiene. Like we dim the lights. Like it's very, very dark. Think like a cave with like a, fire, that type of darkness is what you want to create in your home. On the flip side, light exposure in the morning is incredibly important and super impactful. For my patients who are struggling with sleep and sleep hygiene, a lot of times they're doing all the nighttime things, but they forget about the morning because good sleep starts during the day. So first thing in the morning, going outside and even just getting 5 to 10 minutes of bright light, even if it's winter time, right? Like I'm in San Francisco, sometimes it's just foggy here. But even when you're getting that bright light exposure, if it's not sunny, you're still getting a high intensity of light. So for example, it's pretty foggy today. It's probably about 50,000 lux of light intensity outside versus in my room, even though it's bright in here, it's probably just about 1,000 lux of light intensity. So that outdoor light, even if you just go outside, drink some water, you don't have to, if you can go for a walk, great. But that little few minutes of light exposure in the morning are impactful. And then the other thing I recommend, two other big things. One is have a consistent meal time. That keeps your body clock running on a schedule. So if any of your listeners have pets, that they know exactly what time it is. When, I used to have a dog and he knew exactly his dinner time, 6 p.m. 5:59 p.m. He's like coming to me like ready for his dinner. He doesn't have an iPhone, he doesn't have an Apple Watch on. He just knew internally. So we have that internal clock too. So keeping your lunch as an anchor actually centers your whole day. A lot of times my patients are like, what does that have to do with sleep? But it's actually regulating your clock so that you can sleep on time. And then the other big thing that I think most people forget is to give yourself little micro breaks during the day. Because if you're on the go all day long, your nervous system is activated. It's not just going to shut down at night for you to sleep. We need to intentionally allow our nervous system to downshift with these little micro breaks during the day. And what that looks like practically is just take some deep breaths, put your phone away. Don't look at your email, just take even 30 seconds to close your eyes and take a few deep breaths just to reset.
That's amazing. I love, I was actually taking notes while you were talking because I was like, oh, this is so good. I want to make sure that I remember this, and that's something that you just don't, well, at least I don't think, I can't speak for other people, but it's something that I don't think about. I don't think about taking the breaks because we're so used to like the hustle culture, and I'm in New York and it's all about productivity and like, what did you get done during the day? And, are you moving? Blah, blah, blah. So anyways, it's really, you just, I never slow down. Like I'm, thinking, okay, I got to do this, I got to do that, I got to record this, blah, blah, blah. And so I love the idea of taking like these micro breaks, even if it's, just taking a little, deep breaths and things like that, because as you see patients throughout the day as well. And, it's tough to get that break in between patients sometimes, but I will tell you, when I am able to get in even like 5 to 10 minutes in between patient, it makes such a difference. I feel more rested and I just feel like, okay, now I'm ready for the next patient, whereas if I'm going back to back to back, I just don't have time to like, even think about what it's like I'm still finishing up the note from the previous patient. So I love that idea of taking like micro breaks and having set times, I guess, you're saying for like, are you talking about like all your meals, like breakfast, lunch, and dinner? Are you talking specifically just about dinner? When you talk about that.
Yeah. So for the meals, I mean, if you can do all your meals on a consistent schedule, that's great. That's ideal. I know for a lot of people, myself included, my schedule's kind of different every day. And, like I might be out in the evening. So it's harder to, stay consistent with the breakfast and dinner. But lunchtime is something that if you can make that your anchor, because a lot of us, if we're in a work schedule, many times, depending on what your work schedule is, many times there's like a consistent schedule that you have more or less day to day. So if you can create that little time midday for that lunch anchor, it just centers your whole circadian rhythm. For the dinner in the evening, sometimes patients ask me, what's the best time to finish your meal before you go to sleep? So ideally about 3 hours before you go to bed, you want to have that last meal, because your body, once we want to activate that rest and digest response. And if you're eating too close to bedtime, your body's energy, I mean, this is the very unscientific way to say it, but like your body's energy is going into digestion rather than sleep, right? So we want to, give your body time to digest. But also, if you're eating too close to bedtime, then you can have acid reflux and it can just make it harder to sleep. So, like a good rule of thumb for most people is 3 hours before bed. My husband is somebody who, if he eats a few hours before bed, he actually sleeps worse because it's harder. He just sleeps better if he has something before he goes to sleep, something to eat. I'm the opposite. I sleep better in a bit of a fasted state. So again, these are just general rules of thumb, but I encourage people to tune into yourself to see what your body will tell you. Like your body has that wisdom. It will tell you what you need. So just a good practice as well with this sort of micro breaks is tuning into yourself. What do I need? Am I thirsty? Do I need some movement? Do I need some deep breaths? Do I need to go outside? Like sometimes what I do between patients, like you said, we're seeing patients back to back. I see my patients on telehealth. Sometimes I don't want to just sit and, close my eyes and take a deep breath because I'm sitting all day. So what I feel like I need is like, okay, let me get up, and I'll actually do some squats or, shake it out sometimes. Like in psychiatry, sometimes we're doing heavy work, emotional work with people. And so just like, let me shake that off, or let me just go outside for a few minutes and get that fresh air. So tune into yourself. I think that's one of the most powerful things that you can do, not just for your sleep, but to enhance your overall well-being.
Yeah, I agree with you 100%. So I guess going back to that question, like why women can struggle with insomnia even when they think they're doing everything right. What do you think that could be?
Yeah, so insomnia, so let's maybe first define what insomnia is. So insomnia is difficulty falling asleep or staying asleep at least 3 nights a week for 3 months or more. That's the clinical definition of insomnia. And the difference between insomnia and sleep deprivation is that insomnia is when you cannot sleep despite giving yourself enough opportunity to sleep. So let's say you give yourself 8 hours in bed, but you're only sleeping for 5 of those hours, and you can't sleep during that time. Versus sleep deprivation is like the patient that I mentioned to you, who she's just staying up late trying to catch up on stuff. She could sleep if she went to bed earlier. She's just not allowing herself because she's doing other things. So that's sleep deprivation. Insomnia, too, it shows up during the day, oftentimes with what we call hyperarousal. So this is the person who's like, even if I lie down to take a nap, I can't fall asleep for a nap. Versus the sleep deprived person will be like, okay, yeah, if I lie down on the couch, at 3 p.m. between meetings, I'm going to fall asleep, right? That's likely more because of sleep deprivation versus the insomnia. So why is it that when people are trying to do all the right or doing all the right things that they still have insomnia? Well, the great paradox of insomnia is that the harder you try, the worse it gets. Because oftentimes people are putting a lot of effort into trying to sleep, right? So the more effort you put into it, does that tell your nervous system to be calm? No, right? It tells your nervous system, oh, we're trying hard at something. We better ramp things up. Let's get into our sympathetic fight or flight response. We're working at this. We're trying. So what I mean when I say sleep effort or trying harder is people will do the perfect sleep hygiene, right? They have this, I had a patient who had this 30-step routine before bedtime, like this rigid routine of, right? So first I have to put my phone away. Then I take my magnesium. Then I put on my blue blocking glasses. Then I do this like meditation. And then I listen to binaural beats. And then I do blah, 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 30
Wow.
things. And I'm like,
It's a
that
lot.
sounds really stressful. Like, I don't think I'd be able to sleep if I did all that. So people feel like they're doing all the right things oftentimes, but the missing link is by doing all of that, we're getting in our own way of allowing sleep to happen. It's a natural process, just like digestion, like breathing. We don't think about, okay, I have to get, this many breaths per minute, right? I need to get my 12 breaths per minute. We're not thinking like that. If you thought like that, you would drive yourself nuts, right?
Yeah.
But we live in a society now, like everyone's talking about sleep online, 10 steps to better sleep, 5 hacks for better sleep. And it's actually creating more sleep issues. So the most important thing for people with insomnia is learning how to take a step back and let go of that control, let go of that effort. And that's why we called our program Effortless Sleep, to help people with that process.
Yeah. Oh, that's fantastic. So let's talk a little bit about the relationship between sleep, mental health, desire, and sexual function.
Yes. Okay. So I know this is the Muslim Sex podcast.
Yeah.
So yeah. So it's, well, we can talk about it, in terms of hormones a little bit. So, we already talked about female hormones and how they change during perimenopause. And in men, what happens with testosterone is secreted, is very tied to sleep. Unlike women's sex hormones, which follow their own rhythm, men's sex hormones, specifically testosterone, is tied to sleep. So when it's tied to sleep onset. So when a man falls asleep, then his testosterone is secreted. Then it kind of peaks in the morning, and then or peaks during the night, and then starts to go down in the morning. So it's very tied to his sleep cycle. So if a man is sleep deprived, or not getting good quality sleep, or maybe he has sleep apnea, that's going to have a direct impact on his testosterone. So that's kind of on the men's side. We talked about the hormones on the women's side, but there's also the psychological aspects, right? So if women are depressed, and this is true not just women, but if a person is depressed, if a person is anxious, if a person is tired, of course that's going to impact their desire, right? And with depression and anxiety, as a psychiatrist, sometimes the medications that we use for depression and anxiety can also have a negative impact on sexual desire, libido, and things like that. But something that's really interesting is for insomnia specifically, one of the gold standard treatment for insomnia is CBT-I, which is cognitive behavioral therapy for insomnia. That is the gold standard treatment, first line recommended before you even do medications or anything like that for insomnia. So it works really well for insomnia. We also know that it helps depression and anxiety, but interestingly, it's also shown to improve libido in women with low desire, like, sexual dysfunction. And that's even if they're not specifically working on that. So there is that psychological aspect of changing their relationship with their sleep, changing their relationship with themselves, that has a positive impact on sexual function.
Absolutely. So anytime we have any type of sexual dysfunction, we always use the biopsychosocial approach. So exactly what you're saying, right? So with my patients, in fact, I have patients all the time that come to me for decreased libido. And so we talk about, dealing with the biological component of what could be causing their decreased libido, whether it's medications, whether it's, the biology, whether it's the estrogen, whether it's pain with sex, whether it's the decrease in testosterone that's causing the decrease in libido, what's going on in that aspect. We always talk about the psychological component, which is the anxiety and depression or any one of those things, right? We know that a third of women will develop anxiety or depression, even those that have never had it in, midlife. And so that can absolutely affect it. And then, the social aspect of it, right, is of course, if they're not sleeping, that's going to affect if they are, they're in a relationship where they don't feel safe or they no longer feel attracted to their partner. Obviously, that's going to be affected. If they are a single mom working like 5 jobs and sex is just another chore on their list of things to do, that's going to affect it, right? So, I tell women all the time that it's not just one thing. I can't just, I'm not going to give you one drug and all of a sudden it's going to help with everything. It's, all of these things, putting it all into context. And, we talk a lot about, so I'm sure, I don't know if you've heard of Lori Barato, but she is a sex therapist in British Columbia. She does a lot of research on mindfulness during sex and how that increases sexual arousal, lubrication, satisfaction, and libido in women that came to her for decreased libido. And she, they did a study and now there's an app and all this stuff. But, she talks about the same thing. She has a book titled Better Sex or Mindfulness. And so I talk about that a lot with women. And one of the things that always that tends to affect women a lot more than men is, body image, right? So we know that body image also affects desire. And I had a patient yesterday that came to me for decreased libido. And, she said, I just feel dead inside. I don't feel any desire at all for my husband. And her husband is younger than she is. And she's like, I'm afraid he's going to have an affair, blah, blah, or, we're going to get a divorce. And so anyways, there's a lot of things that's associated with it. So, I appreciate you saying that, sleep obviously plays a big role and impact in desire and how behavioral, cognitive behavioral therapy. And I use actually, with my patients, we'll use a little bit of CBT. Obviously, I'm not a therapist or a psychiatrist, but, we'll talk a little bit about that with vaginismus, where the muscles, right, around the vagina become tight in anticipation of any type of penetration. And so a lot of people that have vaginismus, they have those tight pelvic floor muscles, but I tell them that it's not just about, the pelvic floor therapy, which is so important, but it's also about working through the thoughts that you have, right? That fear that this, any type of penetration, whether it's a pelvic exam, a tampon insertion, penile vaginal intercourse, any one of those things is going to cause this severe pain. And so you have to kind of work through that as well. So we talk a little bit about that, but I always refer to, a sex therapist, which helps them out. I refer to a pelvic floor therapist, and then I deal with the anatomical and biological component of it, whether it's hormones, whether it's giving some vaginal estrogen, whether it's dealing with their lichen sclerosis or lichen planus, or if it's having to do pelvic floor Botox for them to help relax them. But yeah, it's totally like a threefold approach that I do. So I absolutely will, suggest people to use cognitive behavioral therapy to help change their thoughts around penetration and vaginismus. So I'm glad you do the same thing. So the relationship between sleep, mental health, desire, and sexual function, I think we were just at that. Okay. Tell me a little bit about stress, mental load, and that feeling of being exhausted, but unable to switch off.
Yeah. So, well, and it kind of ties to what you were just sharing about, and I really like that you mentioned that sort of biopsychosocial approach because, again, we live in a society where we're always like bracing ourselves, right? Mentally bracing for the next thing, physically bracing, and that shows up in tension, like you mentioned, vaginismus, or it may be like shoulder tension, headaches. I see a lot of patients with headaches. So all these different kinds of things, and that's going to not just affect, sexual health, but also sleep and mental health. And so, I think I call this kind of living in the go, go, go club. You're in New York, so it's like, the city that never sleeps, right? So, this go, go, go mentality. I'm in the Bay Area, and it's, different culture in the Bay Area than it is in New York, but there is this kind of hustle culture here too. Move fast and break things, right? That's the kind of motto in Silicon Valley. So, I see they're just always on the go. There's no time. I was talking to another patient of mine, and she was like, well, I would do some of these micro breaks and things like that, but I don't have time. And the thing is that what I talk to women about particularly is that there's never going to be time, right? You're
Exactly.
never going to find that time. We have to take that time back. And no one's ever going to give you permission to take care of yourself, right? And a lot of times we're waiting for someone to say, why don't you just go to bed? Go get some sleep. You're tired. Why don't you take a day off? I think you need a break. No one's going to do that, right? Maybe some once in a while, but hardly ever. Who's going to give you the permission to do that? And so I think it's really important as women, particularly, that we give ourselves permission to do that. And working on your sleep, taking back your rest, giving yourself that downtime during the day, taking the break, taking the day off, going for a massage, whatever it is that you want to do. Working on your thoughts is really important. Like, it starts with that mindset of reminding yourself that you are important and that you can't take care of anyone else. That whole cliche of put your oxygen mask on first before you put it on your child. The more you can lean into that, the more effective you can be. And ultimately, work can wait. Most of the things that we think are urgent that need to be done right away, most of those things can wait, right? What's the worst thing that's going to happen if you don't respond? Like, even before this podcast, I saw this email come in. I'm like, oh my God, I better respond to this email. And I'm like, wait a minute, this email can wait for an hour. So I think we take on a lot of that stress. So I encourage, anyone who's listening, especially if you're struggling with sleep, just take an inventory of how you go through your day. Like, what can wait? What is actually truly a priority or urgent, and what can wait? And what's the mindset that you have? Are you not making yourself a priority? Are you not prioritizing sleep? Are you putting everyone else before yourself? And the more that you can start to work on that, and in our program, our Insomnia program, we talk a lot about values. What are your core values in your life, and are you living in alignment with those? Because the more you can live in alignment and accordance with your values, the more sense of meaning and purpose you'll have, the more you can filter out the noise and prioritize, like, oh, actually, that's not as important. That's not aligned with my value system. And many times, this is a little bit more of the sort of spiritual aspect of sleep and insomnia. It's not just about all the sleep hygiene, all the things that we were talking about. Many times our body is telling us that something is off in our lives, and that often does show up in sleep, right? And many, you probably know that. Like, I know I've had insomnia when something's not going well, or I'm dealing with some kind of problem in my life, or what have you. And when it becomes a chronic thing, that could be a sign that there's something bigger in your life that you're not connecting to. What is that message? So, if you have that spiritual inclination, you can even ask for guidance on that. Like, okay, what is this here to teach me? So again, it comes back to just doing an inventory, doing some reflection, and connecting with your intuition, because your body, your mind will tell you, your soul knows what you need. We just have to connect back to that.
Yeah, I love that your soul knows what it needs, and I agree with you 100%, right? Is to give yourself permission. So many women do not give themselves permission, whether it's with, taking a break or taking a day off or relax, whatever it is that their body's telling them they need. And, for me, it always comes down to when I talk about giving for women to give themselves permission, I'm talking about, more about sex and enjoying sex and pleasure and things like that. But, I agree with you is that oftentimes women do not prioritize their own needs and wants. And so then they, and when they're not living in alignment to their values, I think that shows up in so many different ways, right? We see people having pain or insomnia or, the chronic headaches and all this stuff, right? And I agree with you. I think that sometimes that can be a function of just not being in alignment with what it is that's so important to you. So, we talked a little bit about sleep, how sleep changes during perimenopause and menopause. Maybe we could just go back to that a little bit.
Yeah. So again, the biggest complaint is that difficulty staying asleep and those 3 a.m. awakenings.
Yes.
So yeah, so maybe we can talk about that a little bit. So there's a couple of things. One is it's normal to wake up during the night. So oftentimes I'll hear from patients, oh, I'm waking up during the night. How can I stay asleep the entire night? Well, that's actually not what sleep is supposed to do. Like our sleep architecture includes these brief awakenings throughout the night. Sometimes you're aware of them and sometimes you're not. And why does that happen? Well, our brains have evolved to have these awakenings during the night as a safety mechanism. So if you think about, way back when we were living out in villages and tribes, if there was an invader, if there was like an attack on the village, if there was a tiger coming in, it would be advantageous to wake up in the middle of the night, survey your surroundings for safety, make sure there's no intruders, make sure the babies are still breathing, that the older folks are still breathing, and then you go back to sleep. So it's a safety mechanism that we have evolved to have. So that's the first thing, is normalizing those awakenings. It's actually completely normal. That's our brains are supposed to do that. That's healthy. Now, if you're having those awakenings in the middle of the night and you can't get back to sleep, then we have to look at that. Okay, if you're awake for an hour, 2 hours, you can't get back to sleep. Okay, what does that mean? That could be, are you having vasomotor symptoms, that you're just too hot and your body can't cool down enough for you to get back to sleep? Okay, maybe hormone therapy might be useful. Are you waking up because of breathing issues that you're not aware of? That could be a sign of sleep apnea that we talked about. Okay, maybe get the sleep study. I'm glad you're going to go do that. I did one on myself too, just to make sure. Could this be stress? Anxiety, because the middle of the night, no one's bothering us, no one's expecting us to return that text message or that email. So now your brain finally has some white space to think about whatever's going on in your life. So is there some processing that needs to happen during the day? Could it be hunger? We talked about eating meals. Are you having a hypoglycemic episode? Sometimes wearing a continuous glucose monitor can be helpful. Inside my clinical program for clinicians, where I teach them about sleep, one of my colleagues, she's an endocrinologist, we just did a training on CGMs, for sleep. And, how do you use that data? So is there hypoglycemia? Is there restless leg syndrome? That's more common in women. That's due to low ferritin. A ferritin less than 75 or even less than 100 can contribute to restless sleep, restless leg. So going back to what you mentioned, the biopsychosocial model, there isn't just one. Like, you'll hear influencers on social media go, it's cortisol, and it's like, okay, well, first of all, no, it's not. It's not like, that's not how it works. Okay, if it's cortisol, well, something's increasing that cortisol. What is that? It could be all of these things that I just mentioned. It's not like cortisol itself is just going up and causing you to wake up. No, it's these other factors feed into it. So it's not as simple as, okay, here, take a, extended release Zolpidem and sleep through the night. No, we need to look under the hood to see what else might be going on.
How does depression, anxiety, and psychiatric medications, how do they both affect sleep and desire? And I know that so many of them do, right? Like, especially SSRIs are the biggest ones that affect orgasm and desire, and are just, and something new that I learned, which I didn't realize, is that it can also, you shouldn't give those with somebody that has osteoporosis, that it can make that worse. Can you talk a little bit about that with different medications and how they affect?
Yeah. So, sexual dysfunction is one of the most common side effects of SSRIs. And it's one of the most common reasons patients will ask me to switch to a different medication, because they're having either delayed orgasm or it just kills their libido altogether. Sometimes those effects go away within a few weeks of taking the drug. So oftentimes when a patient starts an SSRI and they're having those side effects, I'll say, let's just watch and wait and see how it goes. And then they might come back a couple months later and go, yeah, actually it was temporary and it resolved. But for some patients, those side effects persist. So in those situations, there's different ways to address it, because if it is truly is drug induced and it's having an impact on their life, because I also want to know, well, how much is this bothering you? And sometimes they'll go, it doesn't really bother me. It's fine. Like, it doesn't affect my relationship and it's fine. Okay. So we'll just kind of keep an eye on it. But if they're like, no, this is really impacting my relationship, it's having an impact on even my self-esteem, how I, feel about myself, then we'll look at potentially switching to a different drug. And sometimes if they're on an SSRI, sometimes even just switching to a different SSRI, from Prozac to Zoloft, sometimes that can do it. Sometimes we switch to an SNRI, or sometimes we can use augmentation strategies like adding in Wellbutrin, or Buspar is another one. There's some research showing that adding in maca might be helpful. And then if it's really bothersome to that patient, then we might switch to a completely different drug class altogether that doesn't have sexual side effects. But we also don't want to forget about all the things that you mentioned, right? Like, what is your relationship like with your partner? Do you feel safe? Do you feel, loved in that relationship? Do you feel connected? Do you feel like you're on the same page with, expectations about what intimacy looks like? Do you have, struggle with your body image? How are you feeling about yourself? So we don't want to put all the blame on the medication. The medications can certainly cause those side effects, but we also want to look at the different aspects. And sometimes working on CBT, so I had a patient who, it was a male, and he was struggling with some of these side effects. And then he was working with a sex therapist with him and his wife. And he came to realize that, okay, yeah, the medication was contributing to it, but he's like, no, this is much deeper than the medication. And they were able to uncover that through the work with the sex therapist. So again, I think you and I have a similar approach of like, let's look a little bit deeper and see what else might be going on.
Yeah. I think that's really important, and that takes a lot of reflection, right? And the relationship, but also sometimes, we're afraid of the answers. So, people don't want to go in much deeper. I was just thinking about this and the cultural factors that may influence sleep, stress, and how women seek help, including in South Asian communities, which, we're both South Asian. I'm Pakistani. Are you Indian?
Mm-hmm. Yep.
So, yeah. So, I think that, well, there's so much taboo around sex, first of all, and shame and guilt and all of that. That's kind of built in to the culture, unfortunately, which I like to say is, did not come from our heritages, but actually came from colonialism. And when we were, under British rule for so long, that they imparted their puritanical beliefs on us, because, I mean, Indians had the Kama Sutra, and, Muslim and Islam is actually a very sex positive religion, which I had to learn myself because I grew up, thinking that, sex is wrong, it's dirty, it's shameful, we don't talk about it, all these things. And then I was like, wait a second, that's not what my religion says, and I'm a religious person. So anyways, whatever, it's just finding out what our own heritage and beliefs are, and realizing that, these values were imparted onto us and weren't necessarily, something that were part of our tradition before we were colonized. But what do you think?
Yeah, no, I completely agree with that. It's funny that you bring that up too, because so my family's originally from India, from Punjab. My grandfather, my mom's dad, lived in Lahore in Pakistan before the partition, and so they had to flee, during the partition in
I'm Punjabi
1947.
too.
Yeah. So absolutely, I completely agree with you. And it's funny. I was talking with my husband about this the other day, about this very thing about colonialism and how it created this sort of puritanical view, but also sexualizing things that were not sexual. So it created this very confusing sort of perspective on things. So, for example, I was reading about like the saris that women wear, right? They never used to have a blouse underneath; it was just a wrap. And when the British came, and so you can fact check this, because I don't know if the source that I was reading was fully accurate, but it kind of made sense. So fact check this for sure. But that it was a wrap. And then when the British came, they were like, oh, that's inappropriate. You have to wear a blouse underneath, and that's where that sort of came from. And even practices like in India, there's different spiritual practices and things like this where people might not be wearing a lot of clothing, and it's not sexual at all, but it was sexualized. And then the other way, like you said, with Kama Sutra, and even in the Vedas, like Tantra, you mentioned sort of mindfulness for sexual health. Well, that comes from these traditions, right? Where like in Tantra, it's not this like, scandalous, like, lascivious thing that it's been made out to be in the West. There's actually a spiritual process behind it. It's mindfulness, it's connection, it's breath, it's being present, right? That's what it is. In the West now, they call that mindfulness, but it comes from these traditions. And so, yes, I completely agree with you on that perspective. And then, for South Asian modern women, a lot of expectation has still been passed down, even in 2026, right? And like, who's making the tea? Who's making the chai? in the house? Like who's serving the dinner? Who's making the rotis while like everyone else, the men are sitting? It still happens,
Yeah.
right? And so there's all of this baggage that women are carrying as well, and so that leads into sleep issues, mental health issues, sexual dysfunction, all the things that we've been talking about.
Yeah, absolutely. And there's so much sexual dysfunction in our communities. We just don't talk about it, right? There's so much taboo and stigma around mental health, right? Seeking help for mental health. There's stigma around sexual function or dysfunction. I had a woman that found me on social media that called me up, and she was not able to consummate her wedding for 8 years. I was surprised that they were still married, but she had the severe vaginismus. I had another patient that drove down from Syracuse, which is 4 hours away from where I am, because she didn't have a provider that could do public floor Botox for her, but for her, it had been a year and she wasn't able to consummate her wedding. So, these things happen, and we just really need people that understand, that are compassionate, that won't judge, that can help you out. And she said that she went to providers that were near her in Syracuse, and they all told her, the same very dismissive things like, have a glass of wine, and the woman is Muslim, she doesn't drink wine, or they told her, you're too stressed, you need to relax. And, it was just things that were not helpful to her. Whereas, she's struggling in a relationship, in this marriage, and she doesn't know what to do. And so I think it really, takes like some sensitivity, right, in a cultural lens, just to see what is going on with that patient and how you can best help them. And I'm sure you probably do that yourself when you're dealing with all these sleep issues. So what about when the insomnia and fatigue or poor sleep, when should they prompt like a formal evaluation, right? Like you and I are talking about like these sleep studies, but there may be somebody that's listening to this podcast and saying, well, I don't know, I don't know if I'm having issues, maybe, but I just don't feel rested.
Yeah, so I would say don't wait to talk about it, because a lot of patients, they just don't bring it up because many people are just living with poor sleep. It's actually a public health crisis. Like the CDC has said that sleep deprivation is a public health crisis. More than 30 million Americans have insomnia, and there's only 7,500 board certified sleep physicians in the US. So there's just not enough sleep doctors. So that's why, I've taken it upon myself to help educate other physicians and practitioners on sleep on my YouTube channel and my courses. But for the patient who's listening, don't wait. Go talk to your primary care physician. You don't have to live with poor sleep. Sleep is highly treatable. It sometimes feels like this intangible thing that, there's nothing I can do about it. But no, it's highly treatable when you have a systematic approach. Go talk to your PCP about it. Go talk to your OBGYN. Talk to, your therapist, your psychiatrist, whoever you're working with. If they don't know how to help you or they don't know where to send you, there's actually lots of online resources. One of them is called Project Sleep. It's a nonprofit, and they have a free sleep helpline. I have a video with them on my YouTube channel. I'm not affiliated with them. They just, it's free.
Yeah.
I had them on my YouTube channel if anyone wants to check that out and just see what they do. But they have a free helpline. So you can just call them up as a patient or even as a practitioner and say, I'm struggling with insomnia, or I'm struggling with feeling sleepy all the time.
Sure.
And they will guide you, and they can give you resources in your location and your state. So that's a good resource.
Yeah.
And then Sleep Foundation, I forget, can't remember if it's .org or .com, but if you Google Sleep Foundation, that is a resource with lots of information about sleep as well. So talk to your practitioner. If they don't know where to guide you, you can try these other free resources, but don't give up. Sleep is highly treatable, and there is help available.
Yeah, we didn't really talk about this too much, but you mentioned a little bit in passing about restless leg syndrome, and you said for ferritin, did you say less than 75?
Mm-hmm. Yes.
I thought it was less than 50. So less than
Yeah.
75, so it's actually even higher than that, right?
Yes. So there's new guidelines that came out in 2025, I think it was, by the Restless Leg Foundation. And I think the new guidelines are even less than 100. I have to double check, depending on which guideline you look at, because there's AASM and then there's the Restless Leg Foundation guideline. It's much higher than what most people realize. So I'll have patients coming to me with restless sleep. They don't necessarily even have restless leg syndrome, but they'll have restless sleep. They feel unrefreshed, especially women. And, I'll say, oh, did you get your iron levels checked through your, they may have had labs done elsewhere. And they'll be like, yeah, it was normal. I'm like, okay, well, normal does not mean optimal. And so I usually want to know, well, let me see the actual results. And then normal, their ferritin was 30, right? Because that's still in the normal range. I'm like, no, okay, so you can have restless sleep from low ferritin, even if you don't meet criteria for restless leg syndrome. That's one of the first things we do in my sleep clinic is we get those baseline labs and pay particular attention to iron. And repleting those iron levels can have a big positive impact on their sleep quality.
It's so interesting. Why is that? Why is like iron such a big?
Yeah, so iron is involved in dopamine synthesis. So to produce dopamine, we need iron. It's an important cofactor in dopamine synthesis. And dopamine is involved in movement. So if we have this sort of like dysfunction in our dopamine system related to the low iron, it can create these movements. And that's the mechanism of restless leg syndrome. But even if they don't have a diagnosis of RLS, you can still have a lot of movement in your sleep. So actually one of my colleagues, he's a psych nurse practitioner. He sent me his Oura Ring data the other day. He's like, can you just take a look at this? And he had all this movement in his sleep, no restless leg. And I'm like, what's your ferritin level? Like, it looks like you probably have a low ferritin. He's like, yes, I do. So that's kind of how it can show up. And so it's related to that dopamine dysfunction.
So interesting. That's great. So, what is, for somebody that is listening to this podcast, what would be 3 pearls that you would want them to take away?
Okay. Ooh. Okay. So I think number 1 is that insomnia is not always insomnia. It could be a sign of all the other issues that we talked about today, different sleep disorders or, biopsychosocial. Number 2 is that sleep issues are highly treatable. So if you're struggling with sleep, don't hesitate to get help. And number 3 is take care of yourself, tune into yourself and see what your body, mind, and soul need.
I love that. It's amazing. Well, this has been such an amazing podcast. I'm so glad you came on because I learned tons of stuff and I wrote down and was trying to take notes while you were talking. So that tells me that I'm learning. But for all those people that are like, wow, Dr. Bhopal is so amazing. How can they get in touch with you? How can they work with you?
Yes. Well, you can come find me on YouTube at IntraBalance, INTRA Balance. And you can also connect with me on LinkedIn. Just look up my name on LinkedIn, come connect with me there. And then you can, if you're looking for support with sleep or mental health, come to my website, pacificintegrativepsych.com.
Okay. And what about on your social media? How can they follow you on social media?
Yep. So all my socials under IntraBalance, so INTRA Balance. Instagram, YouTube is my primary channel, but you can find me on Instagram, Facebook, and then LinkedIn under my name.
Amazing. Well, thank you so much for coming on. I know I learned tons of stuff. And well, we are done here and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. If you have any questions about your health, specifically your sleep health, insomnia, any one of those things, make sure you go speak with your primary care provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.